Hello and welcome to the EMS Improv Podcast, where we engage, where we're mindful, and we share and tell our stories. I'm Eric Chase, and we are powered by GEMS. Ladies and gentlemen, I'm very excited again for this guest. He is somebody that's most notably known as EMS Adventure. And ladies and gentlemen, we want him to also be known by Jimmy Apple, which is his actual name. So Jimmy Apple, name, EMS Adventure, who he's known by, is an actual human being. I can look at him right now. He's in Georgia. Most of you have heard him or seen him somehow. They've just got the podcast going again, relaunched the EMS Adventure podcast. So we want to tip of the cap to them and their sponsor, Zoll. They're doing great things. Yet the human, the man, the educator, the person that has a heart, has compassion, that is really conscious and wants cardiac arrest survival, out of the hospital cardiac arrest survival, and so many other things to be topics that are near and dear to his heart that he goes around the country presenting. Ladies and gentlemen, without further ado, and that was long-winded, Jimmy Apple, I'm going to say it again, Jimmy Apple, aka EMS Avenger. Go ahead, sir.
I appreciate you having me on. That was quite an introduction. Thank you.
Well, I appreciate that. And I tend to get long-winded to the chagrin of my wife, particularly when we're out on a date. With that being said, I have followed you. And when I sent you an email and then you responded that it went to your spam, I was bummed out because, EMS Improv, it's been a thing since 2017 when Peter Antevin and I were sitting together in Davie, Florida, and I got this and that. So first thing, and I mentioned his name, relationships matter. And you've built them and you're building them. And you and I have a mentor, a friend, a chief cheerleader in a gentleman by the name of Dr. Peter Antevin. Whether it's about him or other people that you've met and that you're seeing across the speaking circuit that are actual real human beings, tell me the importance about relationships, engaging with people, and what that means to you and how you can use that to build a professional brand, and whether it's brand or just facilitate the education that you're doing.
Well, before we even get to that, let's just establish the value of relationships in EMS and the value of human connection. We tend to, in EMS, get very isolated and siloed away from the rest of the world. And there's a lot of people who are in EMS who are out there working under some pretty intense conditions, and it has started to become all EMS all the time for them, as far as working overtime, trying to make ends meet, and they don't get out, they don't get the conferences, they don't meet people, and all the opportunities that you are going to get in EMS comes from the networking that you're going to engage in outside of EMS. There's not a lot of upward mobility in EMS. We all know that, 40, 50, 60 people could be working under one supervisor. So where is the opportunity there for the people there that are working in the field? It doesn't exist. And so opportunity is either up and out or by getting unique opportunities that may be offered to you by actually meeting people in professional spaces that don't involve holding the wall of the hospital. So, conferences have been the biggest thing for me in meeting people. The very first conference that I went to was a local EMS conference here in Atlanta called the Metro Atlanta EMS Conference, which actually is next month, February 5th and 6th. I'll be speaking there. There's actually some great speakers that are going to be there. This is like national personality type speakers for a very low price. But I met Jeff Jarvis there. I met Tyler Christofouli there. I met Ginger Locke there. I met so many cool people there, and that immediately opened up my world into EMS and created a lot more opportunity there. I attended the South Carolina Resuscitation Academy, which is held in association with the Seattle Resuscitation Academy. That was put on by Tom Boothole, who I met at the Metro Atlanta EMS conference. At that conference, I met Peter Antevin, who we started talking in a hallway, and then we ended up talking for an hour. And since then, we've become closer and closer and closer and closer to the point now that I consider him a really good friend and a mentor who has opened up so many doors for him. And all of this has opened its way up into meeting all of these people who are influential in EMS. And it's just knowing these people that have created opportunities. And it's, I don't want to go so far as to say it's not what you know, it's who you know, because it is what you know and who you know. If it wasn't actually, if you weren't a capable person, these people aren't going to give you opportunities. But that's how getting these opportunities goes, is by going where these people are going to be.
And I love hearing that. And thank you very much for at the very beginning, just kind of peeling it all away and talking about the isolation in EMS for so many providers, for so many clinicians, that this is all they know, and they don't take the time, don't have the time, or don't make the opportunities, or their mental health and their perspective doesn't allow for them to create space in order to have this separation. So I appreciate you delving into that.
And there's people who recognize me from afar, my potential, that I didn't realize that you're even watching, and they threw opportunities my way. And I'm really grateful for that. Specifically want to mention Eric Bauer with Lightbridge Ed. He served as a mentor to me early on and gave me some opportunities and just gave me some awesome tools to kind of like power my way to my goals. And it without someone recognizing my potential, without even me realizing that they were watching me, I wouldn't have these opportunities either.
And I would say that's the same thing for me. I'll be in Pennsylvania in a week or so, and it came from talking with one person who saw or heard something, and then that with Peter specifically, he wants to know the science behind stuff. So I showed him our values and numbers and data and stuff like this. So then I did a presentation on the Florida EMS directors thing a couple years ago. With all that being said, it just takes effort and tenacity and willingness, and there's a consistency that I think matters, whether that's consistency in leadership or consistency in what you do and the value of what you think you bring. And we all need cheerleaders on our teams. And I know you've been a cheerleader for people, and I know Peter is one for both you and me. How do you become a cheerleader, and what does it take to do that for somebody that's maybe limping along, and yet you see the value of what they can do, and they just haven't been given that break? They're right on the precipice. But talk to me about, and the listeners, what that cheerleader kind of looks like and how you've done that for people and why you value that and how important that is.
So I'm glad you bring that up, because in order to be, I think, healthy in a space where you are influential, you need to have an inflow and an outflow, so you need to be paying it forward. And that is something I believe fully in. And you need to be an accelerant to other people's creativity, and get behind people who are doing good work. And I don't care if you're in competition with them or not. People who are out there doing good work, you should be acknowledging that. And there are other people who are kind of in the same space that I'm in, content creation, and now kind of starting in like the Reels format on TikTok and Instagram and that sort of thing, and now have really kind of like spread out a little bit, and you see them on multiple platforms and multiple mediums and at conferences and things like that. And so two people specifically who I've recognized their potential, they've developed their own following, and they just needed a couple of breaks, just like I did. Paramedic Sophie and Ashlyn Odell. Yeah. If I get a conference invite, I'm like, hey, have you considered Sophie? Have you considered Ashlyn? They both want to be at conferences. They both want to start, presenting. And so it's simply just, the opportunities that I get, making sure I'm advocating that other people who are doing good work are getting those opportunities. And even something as well is like, when you see somebody who is really owning a space, then what I want to do is, instead of attempting to be all things to all people, is starting to just recognize where somebody is doing very good work in specific subjects and maybe backing off a little bit on like the content I was creating there. So for instance, Paramedic Sophie is really creating a lot of content, a lot of amazing content on EMS culture. And so I really like to direct people to her content. I'll create content on something clinical, and people are like, why aren't you talking about EMS culture? Because Sophie is talking about EMS culture. I was going to create some content on precepting, but Ashlyn Odell is really getting ready to make a push into delivering content on precepting. And so I want to fan Ashlyn Odell's flames on that content for precepting, because that's a space that she wants to own. So that's kind of where I see my role there in making sure we give other people opportunities. And I do want to say to people who are out there creating content, there is a caveat. No one can carry you across the finish line as far as success goes. You do have to succeed to a greater or lesser degree under your own steam and establish that there is a demand for what you're doing. And if you do that, other people will recognize that and simply fan those flames. If you are just asking for clout by wanting people to just mention your name or throw followers your way, it's not going to carry you to victory. You actually have to effort it and create your own results to start with.
That makes me think of two different things, and I want to appreciate you bringing up Ashlyn and paramedic Sophie, because these are also women doing big things, which sometimes are not highlighted in EMS. And then also other people doing big things. And it reminded me of going to for example, a fast food restaurant now that used to 15, 20 years ago specialize in, we've got and I won't do their mantra because I'm not doing a commercial for them, but now they've got 15 types of different ethnic sandwiches or things like that. And they don't do anything well now. They just do it all. And kind of you giving the nod to other people that really want this space, Odell doing, precepting. Why take up and compete for something that you see somebody else doing really well and that you can also support by, at the very least, just not competing. And I think that's amazing, because I think attitudes, perception, feelings, there's people that don't like me and they couldn't articulate a reason why they don't, but maybe just my energy is off. And I have to accept that. And yet there are people that you work with that don't like you because you've worked hard and achieved something that you enjoy doing, and yet they're still trying to sling arrows and knock you down, bring you off a pedestal. And that's always, to me, confounding, because in leadership and in support, my goal is to always allow people to move past me, to help facilitate launching them beyond anything that I've ever achieved. And I've gotten to achieve a lot of things in my 58 years of life. And I could have gone further in some ways because I've held myself back. And in other ways, I've made horrible decisions. And, I've paid the consequences of how that's limited me. When we talk about relationships and accountability, which is leadership, for both you, the individual, and the people that we are around and supporting that, and not to get into the culture specifically, but what you do and what you bring and how you hold yourself accountable to the topics and the education and the data. And this is kind of getting into the evidence-based, because there's going to be naysayers all the time that as soon as you ask them to articulate a reason why they disagree, it's just almost to be a contrarian, because the effort, the evidence, the science that they have, that they try to support or present is really not there. It's pseudoscience at best. How do you deal with that type of individual or groups of people?
Well, the only real way to quote unquote deal with it or respond to it is just to refer back to the data. We have become so ensnared in the culture of the internet discussion that things quickly devolve from a discussion about data to essentially culture clashes, and the way to avoid that is just not to go there. So you can tell when somebody is making a good faith argument or a good faith disagreement. And so I will engage in good faith with that, even if I think they're misguided or discussing from a bias. And that can usually end up in a respectful discussion, even if you don't really end up ultimately agreeing. But I have found that, just sticking with the data is the best way to go. It doesn't personalize it, but you can also tell when somebody isn't arguing in good faith. You know, you can tell that the response is a very veiled, a very veiled admission that they just don't like you. And what's the point in engaging with that? Their goal is not to be swayed. Their goal is to just make sure that you know they don't like you. And so I just don't engage with that, and I don't give it any oxygen whatsoever. And I also don't personalize it. Like, I don't take that personally. There are some times where and it doesn't happen very often. And it's something that I ponder about a lot, because when you talked about women creators earlier, that when women creators are disagreed with, it is very, very nasty and toxic coming from men. But when I'm disagreed with, it is rarely so. But you know, when it gets to be fairly significant, I ask myself, is this person actually okay? And so I'll tell them, hey, you know, all data aside and disagreements aside, and I mean this seriously, I just want to make sure you're okay, because the response that you just gave is from an emotional regulation standpoint is like way out there. And so I just wanted to offer you this resource, and I will put a link in there for mental health resources for first responders. That's the way I deal with kind of like an overly aggressive response.
You know, that's interesting. And I feel that, as well as just kind of heard you tell that story. And I hope for the listeners, the crossover listeners, and then our followers and the new listeners that are going to want to see who this EMS adventure, aka Jimmy Apple, is. You talk so beautifully, articulately, with the foundation of science, because sometimes I'm like, wait, I haven't heard that. Let me go see where that data is. And you always do a very good job of also saying where this is coming from, what study that you're presenting, where the data that you're presenting is coming from. And I always applaud that, because I send this to my crews on a daily, weekly basis. Your reels in particular, because, you know, the mindset, the attention span of an adult is very limited at times. And plus we're working, we have life and everything else. So I want to say thank you for the reels, because it's really helped pick up and improve our just kind of knowledge base in inquiries into certain areas of education. Two things that I want to touch upon. You talked about cardiac arrest, and I want to get there here in a minute, but the significance and the mortality, morbidity of, and clinically it's sepsis, and those correlations, because that was one of the big things. And we're actually going to do a sepsis training on our crew, our shift, as a direct result of that reel that we received from you and your content and creation. So I want to say thank you, because we do the pit crew really well in CPR, but we also know the outcomes and the measurables are pretty lacking there. Before we get to that, and I don't want you to forget that as part of the content that we get there, and the importance of making other aspects of medicine important, because the general public doesn't know, and many of us as providers don't do a good job on, once we get our paramedic or become a paramedic professional, a paraprofessional in place of a physician, is what it actually means to be a paramedic. We don't elevate ourselves to that degree. And you talked about an emotional response. I want to just be open and honest with you about an emotional response, because I saw your post about cardiac arrest and people dying and doing field pronouncements within the last week, 10, 12 days. And sometimes days are crazy, and I don't know what day today is, let alone what yesterday was. So when the emotional response kicks in, and I actually had one this past week, had a suicide, a completed suicide, and then about 12 hours later, a suicide attempt, for which this individual to this point has survived, and yet it was pretty graphic. And I have to be very careful what I say, because HIPAA and all that kind of thing, but and then not identified to a specific individual, family, or place that we are, but it brought up visceral responses within me. And then it was fortuitous, and the universe coming completely together, that I had therapy scheduled, counseling scheduled that very next day at the end of my shift. And we do 4896s, because we're busy enough and not too busy. And so it just works for us. And I hear people already arguing about the efficacy of that schedule. That's what we do, and it works out well, and we haven't had an issue, knock on wood. We look at the numbers, we look at our sleep times and patterns, and we're good. So with all of that being said and addressing that, I had a visceral response that was outwardly made other people potentially uncomfortable. And I wasn't doing anything that was bad, weird, goofy. It was just, that's not his normal. And I had a coworker come up to me and just said, hey, are you okay? And at the time I knew I wasn't, and yet I wasn't comfortable enough delving into the why I wasn't. And yet it allowed me or brought me to that point when I was at therapy, when I walked into Hannah's office, and I wanted to go, yep, perfectly fine. I'm sitting on the couch. She's sitting over in the chair with her legs crossed. And then I have tears rolling down my face. And I said, I am not okay. This is what happened. And this is the response that I had. And I've seen every face of every completed suicide for the last 20 plus years. And they've all played over. And I'd never done EMDR for that. And I looked right at her with almost snot bubbles coming out of my nose. And I said, I need to do EMDR right now for this. And we did. And over the next 45 minutes, almost an hour of our clinical time together, I left clear, free, safely processed. I know where all these places are now, all these faces, all these names are safely put away. That if I need to review those, I know where they are. It's not like that cabinet that isn't closing and slamming and keeping me from rest and sleep and making me drink or, gamble all the time. And it worked out well. And I just want to say that I would have hoped that I would have scheduled counseling. But in this case, the universe put it that I had to go anyhow because I'm paying for it. And I also love it, to be quite honest. It's refreshing. You talked about that in the mental health piece, and I want you to kind of go where you want to go. But I had to share that story because listening to what you say and reading what you write, I felt a familiarity, and I said, wow, if we as professionals and also people, quote unquote, are listening to and watching on a regular basis, if I can't be vulnerable and transparent, how will you choose to do that? And let me just put that out there to you, wherever you want to go with it.
So initially, when you said death notifications, I thought you were talking about my EMS World video with Alex Jobber on delivering death notifications after codes. But I think you're talking about the Facebook post I made on my personal account about how I'm still emotionally impacted by calling it. Is that?
Yes.
Yeah. So I can just kind of wax on personally about that. I have reached points sometimes where I've wondered if I've become a little bit too hardened or desensitized to death. And I can remember, so many codes or traumas where we had to pronounce, and, it was something that shook me, and to me, and it's not just a matter of this person in front of me. It's about life as a whole and humanity and about this interconnectivity that we have. And we just lost a little bit of light, regardless of where that light shone and how strong that light was, it just stopped. And that has always been something, the psychology of it all, the humanity of it all has been something that's important to me. I think the grappling with that is important to our journey here on Earth. And so when I see that loss, it's something that's always impacted me to a greater or lesser degree. But I can remember maybe 4 or 5 years ago, just thinking, I feel like I haven't been impacted like that in a while. And I was concerned because I think that for me, it is important to me to have that. I think it's part of the empathy that is required for me to provide good care, to see the humanity in all of it. We had a cardiac arrest that I responded to in a nursing home for a gentleman who wasn't all that sick, but then kind of like got very sick very quickly. And we were working him, and he ultimately didn't make it. And I don't think his wife was aware of how sick he was. And she got there after we had called it. And I just remember thinking, I don't feel anything. I just don't really feel that much. And then she got up on the bed and she kind of spooned him and held him and just started quietly weeping. And it just suddenly occurred to me that, they were both in their 70s or 80s, and that she, for, 75% of her life now, this was her other half. This was somebody who, for all intents and purposes, she was intertwined with, and life didn't stop with her and begin with him, separated by any sort of a gap. They were one person, and now she suddenly is half a person. She's feeling like she's half a person, and she's lost her soulmate. Ooh, that got to me. And it was reassuring to me that I still kind of understood how important it was to understand human connection. Mm-hmm. And so the other day when we had to call, it was a traumatic arrest, and people just started to quietly disperse, because that's what happens. You're in an emergency room and you just have to keep on keeping on. And it wasn't even the patient that I brought in. I was just assisting. We weren't on a call. And so it was just something I jumped on, and I had to go somewhere and be quiet for a little while. I think it's integral for me to feel the humanity of it. And not only that, but to recognize the innate value of every human life. Like we see some sad stories, people that got to the bottom of the ladder as far as what they could hang on to in sustaining their own life with their own resources. And that could be substance abuse disorder, be homelessness, being unhoused, being, very unhealthy, having mental health struggles, however, that they came to an unfortunate end. The process of working out their innate value to humanity, to me, is one of the most important things above all else. And so it is important to me to assign the value to their loss that I would assign to anyone.
I firstly, thank you very much, because when I saw you give that woo, and I know when the viewers and the listeners see that, hopefully they're also going to associate that with a feeling that lets them feel as engaged with humanity as we need to be, in my humble opinion. And then once you feel that it's overwhelming, or you're not feeling, and that disassociative not feeling that you've talked about, that we get the help and resources. And we know peer resources are important, as long as there's that true confidentiality and that integral piece of not talking about other people behind their backs, because, we as humans tend to sometimes be telling other people's stories when we shouldn't. So I just, again, want to say thank you for, kind of recognize that in yourself, and then being able to say that and put that out to the viewership on your side and on our side, and the merging of it together, that EMS Avenger is a human being. Jimmy Apple is a real person, and not devoid of the reality and the truth and the hurt and the pain of life and what we do. And your primary practice is pediatrics, so you add an extra notch of emotional consequence, to that when there's an adverse outcome of mortality and morbidity with a pediatric, and we look at the fragility of life and then go, that's not fair, and that really, really sucks, and F this, and it can take us into this spiral of downward darkness and behaviors that just don't serve any of us well, and our loved ones. We've got about 10 or 15 minutes left, Jimmy, and I want to tip of the cap, and I asked you not to forget, and I certainly didn't, the piece about evidence-based medicine, clinical practice, doing what's really well, and your focus on out-of-hospital cardiac arrest and how we do that. And, I know that you're working with Cambridge, and so then that's, goodness gracious, what's her name? Well, Tom Boothele was out there, Kelly Boothele. She's big in EMS world too, and man, I'm going to smack my hand for not remembering. She's also a Cambridge associate professional. She's doing that 60 Minutes to Live or Survive.
Hillary Gates.
Oh, yes. Hillary, another amazing human, another amazing person, another amazing professional. And it's funny, like I'm wearing this shirt and it's actually purple, but it doesn't look as purple on the screen. And she said it just wouldn't be you when she sees you if she's not seeing me in that purple shirt. So we have these things that we associate with. And she's always wearing these beautiful red pants at conferences. But my point to all that is each of you in those areas are doing great work and also carrying the work and the data of other professionals, scientists, clinical practitioners, providers, all levels of scientists and clinicians putting that together. And you had put out a reel recently about, mentioning or, nodding to out of hospital cardiac arrest and wanting to do that. But there may be 450,000 or more out of hospital cardiac arrests that don't survive. And then you made the correlation to sepsis. And I want you to talk about in the last, because this is such a big area of your wheelhouse in this clinical work. And I want to, I'll still give you the last word on wherever you want to go, but can you share with our listeners what you shared about the importance of sepsis versus cardiac arrest, and then not treating sepsis, not taking it, identifying it, and then also not treating it, whether you talk about antibiotics or not, but that's not the biggest point that you made in that reel. So
sure,
I'll give it to you.
So the point that I made, and this comes from, that was actually clipped from a podcast where I talked to Peter Antebi. Mm-hmm. And the point I made was just to set up a discussion was that, obviously cardiac arrest practices are a big part of what I advocate for. We want to increase survival from out of hospital cardiac arrest to be as many people walking out of hospital as possible. And there are not quite 400,000 cardiac arrests in the US every year, and 8% of them will walk out of a hospital and enjoy meaningful quality of life. However, there are millions of people who will suffer from sepsis in the US, and about the same number of people who will suffer cardiac arrest in the US every year will die from sepsis in the US. And so my question is that we train and train and train in cardiac arrest, and we have resuscitation academies, which I'm a huge proponent of Seattle's Medic One program and their resuscitation academy, and have participated in putting on resuscitation academies, including the Georgia Resuscitation Academy, which was put on maybe 7-8 years ago. And we practice CPR, and we have to maintain our ACLS and our BLS, and we rehearse and we go through scenarios and we have mega codes, but we don't do anything like that for sepsis, despite the amount of people that will die from sepsis. And we will treat far more people who are suffering from sepsis every year than we will work codes. And I think providers are by and large unprepared to deal with sepsis and to recognize sepsis. I can't tell you how many calls I've been on where I've arrived, there are already units there that started a process. I arrived and nobody took a temperature. And so they just kind of reported these vague symptoms that didn't really match up with anything. And I always take a temperature. It's just part of my practice. And so got a temperature, and you see that this person is either hyperthermic or hypothermic, and it immediately brings clarity. This person, has a temperature of 104 degrees Fahrenheit, or they're 93 degrees, and they have some other out of whack vital signs. And then you start talking about the story, and you're like, this person is septic. And it's what we do in that very moment that is going to matter the most to that person. Because even one instance of that person's MAP going below 65 is associated with an increase in mortality. And we need to be resuscitating immediately. And that involves breaking ourselves away from EMS dogma that what's going to save that patient is a mad dash through the house, through what have you, to get them to a truck, to the ED. Do we need to act with urgency? 100%. But the very first priority is to resuscitate that person. And I think you're going to see a lot more coming out about sepsis care. I'm going to be talking more to Peter about sepsis care in a lot of upcoming content. I get to see Peter a lot, and so anytime I can grab him to talk about sepsis, we'll do that. We're seeing the results of giving antibiotics in the field to sepsis patients, even though it requires a little bit of clarity in some of the metadata. But yeah, that's where I come from with sepsis.
Well, I appreciate that, and I actually saw you smile talking about it, and I know that there's such a passion there, and I know you've gotten asked your why before, and where this comes from, and we're both relatively the same age, and post nominals, and do they really matter? And once you create enough kind of advocacy for yourself, and then there's enough support and cheerleaders for you, and then people start to recognize that what you're saying there's scientific foundation to, and then also you're a cool guy or young lady or presenter where you can immediately connect and engage with people. All those intangibles that people don't have, and not everyone has, and yet they wonder why they're not aspiring. They might aspire to it, but they're not successfully matriculating to places that other people have gotten. And there is this thing called those affective skills, and we all have our abilities to interact more or less appropriately and with whatever we have psychologically going on, sociologically, wherever, the nature-nurture argument. And I taught criminology for years, and kind of the social impacts of different things. And then I studied psychology these last 6 or 7 years, and how you start driving it together, and why we respond the way we do. And we're not trained and taught. And in the last several minutes, I understand your why, and I know what you're doing. We've gotten to talk about a lot of things, and you've sparked my mind to continue to want to watch your reels and your content, because I can tell you, I've had in the last 2.5 weeks, 3 drug-assisted intubations that I've been a part of or done. And the first thing, because of people like you and your content directly attributed to your content, and other people that you're also working and collaborating with, what's their blood pressure? How are they oxygenating? And is there a VQ mismatch? And how can I treat them with the best efficacy and the best right this minute, so that there's a better chance of mortality, and decrease their chances of morbidity by the time we get them to the hospital? And I can just tell you, I know that I'm not the only one that watches you within our team and pays attention to your content. So I can't thank you enough, because I hear you, even though you're not literally there with me. Resuscitate before you intubate. Make sure that pressure, that condition. I've started pressors before. We've done a push dose pressor while we're doing the norepi, even though we're getting the ketamine or the etomidate out and then the rock. We're doing it in steps. And I'm grateful beyond measure for Dr. Bill Warden, my medical director, and I'll just put his name out there. He's actively engaged. He wants us to do more. If we can articulate something that you presented and it's outside of our protocols, and yet he can, when he comes to us and goes, why did you do this? We can say, and I know that on your content, you always say, follow your protocols. I'm not telling people to follow Jimmy Apple's protocols or EMS Avengers protocols. Don't do that. If it drives you to learn and study and understand why you can do something, and it's in the patient's best interest, and then you can articulate that to your medical director that you work for and under, then go ahead. I'm again not telling you to listen to my advice. I personally study and then do, and if I do something outside of protocol, I know how to verbalize and articulate that. Like, for instance, and I did get medical orders, but I've used ketamine to stop status seizures. And you know what? It works, ladies and gentlemen. If your protocols don't tell you to do that, then you better be on the phone calling either your medical director or the receiving hospital's medical director and get orders. And oftentimes they're going to say, how far away are you, or how, whatever. But if you can't articulate your what's, your whys, and your hows, your answer is going to be no 99% of the time. Because if you don't trust yourself, they're not going to trust you. So Jimmy, you talked about psychological impediments to taking care of people. You work in the pediatric space. Adult patients, whether it's sepsis patients, I'm afraid to start norepinephrine. How many people have you heard that? Or dopamine? Or which one do I do? Or do I do a push dose?
Not dopamine.
Thank you. Say that louder for the people in the back of the room.
Not dopamine.
Okay. I've had doctors and nurses stop Levophed or norepinephrine and put dopamine up once I've got them to the hospital. I've had doctors go, ketamine for pain? We don't give ketamine for pain. Kindly, thank you very much, and don't argue with them. Hear what they say and refer your medical director to them. So not dopamine, but anyhow, I went off on a tangent, and I'm good at that. My wife, again, to her chagrin, stop talking. So Jimmy, that psychological impediment to us treating, whether it's a pediatric or an adult, can you talk about that? And I want to give you the last couple minutes of time to kind of address that, and then put whatever stamp of information you want to give out to our people.
Well, usually the psychological impediments to treating are kind of different depending on your patient population. For adults, it's usually because you don't trust yourself to know enough about what you're doing. And I don't know if that came out right, but if you haven't used norepinephrine before, and you've heard people say things like, Levophed, leave them dead, which is old dogma, that was not the drug, that was operator error back in the day. Same thing with verapamil, people calling it verapamil. It's actually a very safe drug, and it just was not being administered appropriately. There's actually even some better data for verapamil than there is cardizem. But with adults, it's usually just unfamiliarity, with the procedures, having to perform like, a needle decompression or something like that for the first time. Most providers haven't done that very often. Maybe people that work in very metropolitan areas, where they're getting a lot of trauma. Maybe that's something that they do more regularly. Somebody that works in a more, spread out area, they don't see as much trauma. That may be something they've only done once or twice in their career. I've been in this for about 20 years. I've done about 6 needle decompressions. And, I can tell you the first time that I had serious reservations about doing it. And there's a lot of people that would just rather substitute diesel for acting in the patient's best interest. And there may be a case to be made that if you're not comfortable with the procedure, then maybe diesel is acting in the patient's best interest. So that can be one inhibition to, providing the appropriate care. For kids, it's a whole different thing. And it's because we have made, in the way that we teach pediatrics, we have terrified providers and made them we've made them absolutely terrified to take care of kids. It's the exact opposite of what we should be doing. We should be making providers comfortable with kids and not treating them as distinctly different patient populations from adult, because 90% of the care that we provide in EMS, in both emergency care and critical care, overlaps with adults, pediatrics, and geriatrics. And the only differences really are just guided specifically by the pathology or by the patient's size or weight. And so the notion that kids are categorically and distinctly different from adults is just dogma, and it's not helpful. And all it does is make providers withhold treatment in favor of getting them to the hospital as fast as possible. And these kids can end up deteriorating, reinforcing the dogma of that kids just suddenly crash, which I don't know why we make that specific to kids. Any person that's in extremis will suddenly crash if you don't stop them from crashing. So if you are terrified from treating them, then yes, they will suddenly crash. If you're not terrified to treat them, then you certainly are able to mitigate that crash.
So I love that. Yes, we are all given the tools, at the very least, our authorized procedure list and our protocols and our state licensure and our national registry give us the skills to, when that patient is approaching extremis, that we can actually do something, should actually do something. And if we can't, then there's some remediation that we should recognize in ourselves. And heaven forbid you're clinically held accountable, where it's not supposed to be punitive. And at the same point, if we don't continue, or if we don't improve, if we're not being held accountable, we can't improve. We won't improve. And we're going to operate within, again, you mentioned this about an hour ago, that silo of information, or what is the effect? The Dunning-Kruger,
Dunning-Kruger.
Dunning-Kruger. Yeah, I just had a stroke. Yeah, a little, expressive aphasia right there. Yeah, the Dunning-Kruger effect. So those things are happening, and if I surround myself with people that just, you're great, Eric, and you're a wonderful clinician, and you're so, beautiful at doing death notifications, and we can hear we see the angels and the trumpets are blowing every time that you do one, or whatever. After every call, whether I'm precepting or my partner, where can I improve? It was funny because like a month ago, I was precepting somebody and I said, in one of the categories on the FTO sheet, I just said, please continue to improve. And that kind of gut punched that person. And it was that because, I was rather specific in the other areas, treatment modalities, following protocols, things like that. I said, my expectation of me, and I just had my annual evaluation at the end of 2025, or my quarterly, but it was a comprehensive evaluation. And I said, it always says, and my comments are always, will continue to improve. And when given the opportunity to write my portion of my evaluation, I said, look, I'm looking for areas to continue to improve upon. And if I forgot that I didn't know something when I was on a call, then I'm going to commit to better training, and things like that. And if I don't know why I'm doing something because I forgot the education behind it, I'm going to do more research. So then this person said, you would actually say that about yourself? And I'm like, I expect that out of myself, to continue to learn in that learning process and to associate myself with people that are looking at evidence-based medicine and presenting data that support why we should or shouldn't do things. And this old dogma of, because I was told that way or we've always done it this way, needs to, in my humble opinion, be thrown in the bleep and garbage. And it won't until those individuals change. Mm-hmm. And that's the thing. The impetus is behind each person. In the last couple of minutes here, EMS Avenger, AKA the man, the human, Jimmy Apple, what would you like to say to the listeners, the followers, before we do our closing?
I'm very appreciative of the opportunities that I've been given over the last couple of years. This has turned into something that was just my personal TikTok account where I did a little bit of myth busting here and there and, had some hot takes and that sort of thing. And then quickly became something that I needed to work to keep up on. And it's something where there was just ever increasing accountability in what I said and did. And as I've become more recognizable, I take that accountability seriously. And I'm grateful for every single opportunity that's been extended to me as a result of that. And I take the obligations to be data-driven very seriously. I take the obligation to talk about EMS culture very seriously. I feel that I take the obligation to represent EMS culture very seriously. And this has been just as much as a growth opportunity for me as, any other facet of my life. I've had to look at myself in the mirror and ask myself some very serious questions a couple of times about how I've conducted myself online. I used to be kind of infamous for like grabbing a comment that somebody said that I didn't agree with and excoriating them. Mm-hmm. And I have since determined that if saving lives begins with kindness, then teaching begins with kindness as well. And I try not to approach that sort of. I try not to approach dialogue with people like that anymore. Where it's harsh. I try to extend a kind conversation to people where I can. There's been times where I have stepped out of my comfort zone as far as my knowledge base goes. I have a rule that is, if I talk about a subject and somebody attempts to drag me into the next level of that knowledge and I can't go there with them, then don't make the video in the first place. If I have reached the extent of what I know about something in a video, then I'm talking too much about it, because you need to be able to continue to talk about it beyond that. And there is a video that I released last year where not only did I misunderstand the person that I was responding to, but I misunderstood the chemistry of what I was talking about, and it was embarrassing. And and I take these moments very seriously, and so uh, I want people who are out there that maybe have a bad taste in their mouth for some of what they've seen in the past, that this is a growth process for everyone.
Well, all right. So Jimmy Apple, EMS Adventure, this is a growth process. Paramedicine, emergency medical services, mobile medicine, whatever we're calling it, yesterday, today, tomorrow, forever or never. If it comes out of your mouth and you do it, you're getting paid to help and love people. I say love people because what I do, I love. And I care about the people, even if I'm mad at 3 a.m. because they called. I can't let my attitude or opinion affect them adversely. So then I just go, this is what I love. My wife said, as soon as you start treating people poorly and or me, you need to go to therapy. Again, make an appointment with Hannah or do better. Be self-reflective. Listening to you, watching you, I'm so grateful to you and having you in the back of my little mind here as I'm doing procedures. I hear your voice. I hear clinicians' voices. I hear the data. So I can't thank you enough. And this is a growth process. For each of you out there, this is and has been the EMS Improv Podcast, where we've engaged, we've tried to be mindful, we've shared and told some stories. My guest was Jimmy Apple, EMS Adventure. Again, his name is Jimmy Apple. And we are powered by GEMS, and I'm so honored and privileged to over 5.5 years to be associated EMS Improv with GEMS, and now Jimmy Apple, EMS Adventure, and his sponsor for his podcast, which is Soul. So I want to give them a tip of the cap as well. I'm grateful for you. I look forward to seeing you in Texas in just about a month. And anything else you'd like to say?
I think we said it all.
And may a peace which surpasses all understanding be with you and